The next lecture will be or the presentation will be the ophthalmology for rheumatologists, and the speaker will be the Dr. Khalid Tabara. Dr. Khalid, he's a well-known figure name in this field. He's a professor emeritus of ophthalmology at College of Medicine, King Saud University in Riyadh. He's a former chairman of Saudi Scientific Board of Ophthalmology at Saudi Commission for Health Specialists. Also, he's executive director and medical director of the Eye Center and research director of the Eye Foundation for Research in Ophthalmology, Riyadh. Dr. Khalid, he's a former adjunct professor of ophthalmology of the Wilmer Ophthalmological Institute at Johns Hopkins University School of Medicine in USA. Also, he established the Saudi Ophthalmological Society. It was the first subspecialty society in Saudi Arabia under the umbrella of King Saud University in Riyadh. I'd like to remind you that after this presentation, we'll have 5 minutes for the panel discussion. So please, if you have any question that to be directed to the speaker, you can ask them in the question place or the question area. With no further delay, it's my honor and a great pleasure to welcome you, Dr. Khalid, again in this presentation.
University in Riyadh, Saudi Arabia, and also the medical director of the Eye Center and the Eye Foundation for Research in Ophthalmology. The Eye Center is a private organization which has been involved in research in ophthalmology and was recently recognized as one of the top 10 active organizations in the field of ophthalmology in Arab countries. Over the past 30 years, Saudi Arabia has witnessed great improvement in postgraduate training and research in ophthalmology. Saudi Arabia is now considered to be the leading country in the Arab world in research for ophthalmology. In fact, out of 10 institutions, 5 of them are in the Kingdom of Saudi Arabia, and these are the top 10 active organizations in the field of ophthalmology. Over the next few minutes, I would like to share with you some of the aspects of ocular manifestations of rheumatic disorders, including immune-mediated disorders, metabolic disorders such as gout, infectious disorders, and treatment-related complications. This is a 27-year-old male who presented to me with history of redness and pain in the eye. And you can see there is evidence of peripheral corneal infiltration, and the patient had ulcerative colitis. So inflammatory bowel disease can present and the patient had peripheral corneal infiltration as shown here. You can see there is evidence of corneal infiltration and blood vessels going into the cornea. This is because of the fact that these blood vessels have loops like the loops of the glomerulus, and therefore immune complexes may deposit at the basement membrane of the endothelial cells at these loops at the limbus, creating chemotactic factors that allows the peripheral corneal infiltration. Systemic lupus erythematosus can also affect the posterior segment of the eye, leading to evidence of retinal vasculitis with ischemic changes leading to cotton wool patches and retinal hemorrhages, and this can be vision threatening. In polyarteritis nodosa, which is a rare autoimmune disease, the eye may manifest with evidence of a vasculitis at the limbus, and you can see here evidence of peripheral corneal ulcer in the right eye and in the left eye. And these are manifestations of the vasculitis in the small and medium-sized blood vessels of polyarteritis nodosa. Juvenile idiopathic arthritis can cause uveitis, of course, and this disease is one of the most common cause of arthritis in children. The disease occurs more commonly in females under the age of 6 years, and a polyarticular or oligoarthritis may occur, and the antinuclear antibodies are usually positive in these cases. These are two cases, happen to be at the same time in my office. They are not related. Both of them had juvenile idiopathic arthritis. Both of them had uveitis. And both of them had uveitis, and the one on the left side had evidence of cataract that was operated, and you can see here the evidence of the aphakia in this patient. So it is a common disease causing arthritis, so it can scratch the joint and bite the eye, because this is a vision threatening and blinding disease and should be diagnosed early and treated promptly in order to prevent the irreversible damage and loss of vision in these conditions. This is another child with juvenile idiopathic arthritis showing a tube that has been inserted because of the glaucoma in this patient, and these patients lose their vision because of the glaucoma. In juvenile idiopathic arthritis, you may have calcific band keratopathy, and the calcification is usually in the cornea, at the periphery of the cornea. Why do we have calcification at the peripheral part of the cornea in the exposed part of the cornea? This is because of the fact the hydroxyapatite is deposited in the superficial layers of the cornea, and it is deposited because of the alkaline pH that occurs due to evaporation. Evaporation of CO2 and H2O moves the carbonic acid reaction to the left, leading to decrease in the H plus, and therefore becoming alkaline because of the decrease in the acidity. And this alkaline pH occurs and lead to deposits of calcific band keratopathy in the cornea. Now, this is an important screening guideline for rheumatologists and for ophthalmologists. Anytime we have a patient with JIA, should have initial eye exam. Children under the age of 6 years who are ANA positive should have a routine eye examination every 3 months. Patients under the age of 6 years with ANA negative should have it every 6 months. Children above the age of 6 years who are ANA positive should have an exam of the eye every 6 months, while children who are above the age of 6 years and ANA negative should have annual examination. Patients with Behçet's disease have aphthous ulcers. The ulcers have gray bases and they are painful. And patients may have also genital ulcer. And the reason why I'm putting this, because both of these patients denied the history of genital ulcers. The genital ulcer may be small, but it can leave a scar. And inspection of the genital area may be important in order to find out whether there was history of ulcers in the genital area as well. The patients have skin lesions as well as evidence of uveitis. The uveitis may be associated with a hypopyon, and the hypopyon is very similar to the pathology test because you have pus inside the eye. The posterior segment of the eye is really the ominous finding that you can witness in these patients because they get retinal vasculitis, and the retinal vasculitis can cause the occlusion of the blood vessels and ischemic changes in the retina with retinal hemorrhages and necrosis of the retina and loss of vision. This is a patient with Behçet's disease. The picture on the left side shows the evidence of vitritis and retinal vasculitis. And this is only 5 days after infliximab intravenous injection, with patients showing remarkable improvement in the vitritis, and the patient had complete recovery after the anti-TNF alpha treatment. Rheumatoid arthritis is a common disease, and it can cause deformities in the hand, as you well know. But in the eye, you may frequently get evidence of scleritis. And this is a patient with rheumatoid arthritis and bilateral diffuse scleritis. Peripheral corneal infiltrates may occur as well, like the systemic lupus erythematosus in the periphery of the cornea, and this is a manifestation of rheumatoid arthritis. The scleritis can be diffuse, sectorial, or sometimes nodular, and the nodules can lead to evidence of scleromalacia, thinning of the sclera. And the scleromalacia, if not treated, can perforate. It's called scleromalacia perforans. And this patient had rheumatoid arthritis and scleromalacia. This is an impressionism picture showing the La Lesseuse, was painted by Renoir. And you can see that the face is being illuminated with attention to details and while reading a book. And this is Renoir. I'm showing it because he had rheumatoid arthritis. And you can see the volar subluxation, and you can see ulnar deviation as well, and the changes in both hands. Despite these disabilities and deformities, Renoir continued to paint the impressionistic pictures, and this is one of the delightful charm showing people going up the hill with 16 shades of green. And this is a delightful picture by Renoir. So his disability did not stop him from painting impressionistic pictures. We looked at cases of scleritis and used the OCT, which is a new technology for diagnosis of scleritis. And this is an easy, non-invasive procedure that allows us to look at the sclera and look at evidence of edema inside the sclera. And this edema can help us in the diagnosis of scleritis, and the patient can be treated accordingly. This is a 28-year-old female who had pain and redness in the left eye. She also gave history of epistaxis. She had right hearing loss, rhinitis, and arthritis. The patient did not have pulmonary lesions. CT scan of the chest was negative, and the kidney functions were normal. So this patient had nodular scleritis. You can see the elevated nodule on the sclera with the deep vessels that are dilated. And this patient had positive C ANCA. So polyangiitis and granulomatosis is not uncommon, and we can see them, but early diagnosis and prompt treatment is essential in trying to prevent not only the loss of the function of the joints and the loss of vision, but also it can lead to death. And this is a life-threatening condition that should be diagnosed early and treated promptly. This is patient had biopsy from the nasal mucosa where patient had said she had epistaxis, showing the vasculitis and the granulomatosis that you can see here. And usually the diagnosis is made by having both the vasculitis and the granulomatosis in the tissue biopsy specimen of patients with Wegener's or polyangiitis and granulomatosis. Sjogren's syndrome is another autoimmune disease that can be of two types, either primary, showing the dry mouth, dry eyes, and without a systemic disease, or secondary with systemic disease or autoimmune form of Sjogren's syndrome associated with rheumatoid arthritis or associated with systemic lupus erythematosus. This causes filaments on the cornea which are annoying, and the patient tells you that I have foreign body sensation and sandy feeling in the eyes because of the dryness. Biopsy specimen of the lacrimal gland shows diffuse lymphocytic infiltration of the lacrimal gland. The same picture occurs in the accessory salivary glands, and both of them lead to damage of the acini, destruction of the acinar structures, as well as this destruction of the ductules. This is a mother-daughter pair. Both of them had Sjogren's syndrome. Both of them had dry eyes. But the interesting thing that the patients had crest syndrome, that is calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, and telangiectasia, or the crest syndrome. Both of them had telangiectasia, and the mother, if you look carefully, you can see the evidence of the telangiectasia on the face. In addition to the patient had sclerodactyly and had the Raynaud's phenomenon and esophageal dysmotility with the telangiectasia. Rheumatoid arthritis is a disease that causes deformity, and we can do disease modification by giving the appropriate agents. And now we have overwhelming number of agents that are safe and effective in the treatment of rheumatoid arthritis. The patient may need either the classical treatment using corticosteroids and immunomodulation, such as antimetabolites, methotrexate, or Imuran. And these are still being used, but of course we have the biologics that are becoming more popular now. Calcineurin inhibitors, including cyclosporine and tacrolimus. Checkpoints inhibitors are recently introduced in our armamentarium, and this is because to treat patients with metastatic melanoma or non-small cell carcinoma of the lung. Kinase inhibitors are also used for rheumatoid arthritis, and we will look at the complications that may be associated with some of these diseases. Immune checkpoints inhibitors, such as cytotoxic T lymphocyte associated proteins 4 inhibitors like ipilimumab and nivolumab, these are used for patients with metastatic melanoma. But unfortunately, they can cause a severe form of uveitis, and we should be aware of this complications, which is becoming more common as we use these agents more frequently. And this is a patient with treated with checkpoint inhibitors, showing evidence of uveitis and the area where the iris got adherence. The patients may develop hypotony and as well as severe cystoid macular edema and loss of vision, and the complication should be recognized. In 2018, the Nobel Prize was awarded to Allison and Honjo for discovery of cancer therapy by inhibition of negative immune regulation. Of course, Janus kinase, you know this group of agents because you are using it more and more often. There are several enzymes, the Janus kinase 1, 2, and 3, and the tyrosine kinase 2. They were discovered in 1992, and they are expressed on the hematopoietic cell lineages and form as part of the signaling apparatus. Why are they called Janus? This is because of the Roman mythology, and the god Janus is the god of all beginnings and end, and thus the term January for the first month of the year, and that's why it's called Janus kinase inhibitors. Janus kinase ruxolitinib, Jakafi, can be used for myelofibrosis, psoriasis, rheumatoid arthritis, and tofacitinib is used for Janus kinase 3 for psoriasis and rheumatoid arthritis. Both of these agents can cause ocular manifestations, and it has been reported by several authors that you can get bilateral toxoplasmosis in patients with on ruxolitinib, and therefore one should be aware of this bilateral, as shown here, bilateral toxoplasmosis that can cause loss of vision. This is another report on the development of bilateral acquired toxoplasmic retinochoroiditis during erlotinib therapy. And we should be aware of these complications to stop the treatment and prevent the further deterioration of vision in these patients. Biphosphonates can cause scleritis. Biologics like anti-TNF alpha, like adalimumab, infliximab, etanercept. But unfortunately, etanercept can cause uveitis itself, and this is why Enbrel is not recommended for patients who have uveitis in juvenile idiopathic arthritis. One should be aware of the uveitis that can occur with the use of the anti-TNF alpha. And sometimes anti-TNF alpha can cause demyelinating diseases and rarely psoriasis. So it is paradoxical to see an agent which is used for the treatment of psoriasis at the same time causing psoriasis. And finally, I would like to conclude with hydroxychloroquine that is used frequently in rheumatology. The indications is for rheumatoid arthritis, systemic lupus erythematosus, and malaria. Hydroxychloroquine binds to melanin, and therefore it concentrates in the retina at the retinal pigment epithelium and causes retinal toxicity, which cannot be predicted. And you can have risk factors for hydroxychloroquine toxicity, including short stature, a dose over 400 milligrams, that is over 5 milligram per kilogram, longer than 5 years, underlying retinal diseases, and above the age of 60. These patients on hydroxychloroquine should have an annual exam. Toxicity is rare before 5 years of therapy, and early examination for those with risk factors should be done in order to stop the treatment if needed. This is a patient who developed bull's eye, which is a late complications of hydroxychloroquine retinopathy. Hydroxychloroquine toxicity can cause OCT changes, and this is new technology that shows parafoveal thinning. If detected, the drug should be stopped immediately. So in conclusion, we can say the joint and eye share histologic, immunologic, and biochemical characteristics. They are the target of insult by immune-mediated infections, metabolic and drug-induced disorders. There is a multidisciplinary approach, and the collaboration of rheumatologists with ophthalmologists is highly desirable. To feel is emotion, to think is philosophy, to believe is a religion, to know is science, and that's what Tolstoy said, but I say to appreciate is art. Thank you very much.